Hi, I'm Amanda Spitkowski, and I'm a student at East Carolina University, and today I'm going to talk about the Advanced Practice Registered Nurse Consensus Model. Historically, the nurse practitioner role was created for rural primary care. Currently, there are over 267,000 advanced practice registered nurses in the U.S. The Advanced Practice Registered Nurse, or APRN, consensus model provides guidance for states to adopt uniformity and the regulation of APRN roles. According to the American Nurses Credentialing Center, or the ANCC, the model was developed because the consensus model for APRN regulation, licensure, accreditation, certification, and education is a uniform model of regulation for the future of advanced practicing nursing that is designed to align the interrelationships among licensure, accreditation, certification, and education. The ANCC anticipates that the consistency and clarity that result from the new regulatory model will benefit individual nurses and enhance patient care. Many states use varying models or varying portions of this model. Each state independently determines that the APRN legal scope of practice, the roles that are recognized, the criteria for entry into advanced practice, and certification examinations accepted for entry-level competence assessment. With each state being independent, this creates a barrier for APRNs to move from state to state. This model comes from the Advanced Practice Nursing Consensus Workgroup and the National Council of State Boards of Nursing, the NCSBN APRN Committee, working together and forming the APRN Joint Dialogue Group. As of 2010, there were 48 organizations that endorsed this model. The APRN model of regulation defines 4 roles: the Certified Registered Nurse Anesthetist, or the CRNA, the Certified Nurse Midwife, or the CNM, the Clinical Nurse Specialist, or the CNS, and the Certified Nurse Practitioner, or the CNP. These 4 have training in their roles, plus at least one of the 6 of the following: family and individuals across the lifespan, adult gerontology, pediatrics, neonatal, women's health and gender-related issues, and psych and mental health. It requires 3 separate graduate-level courses in advanced physiology and pathophysiology, health assessment, and pharmacology, along with clinicals. They must take the certification to assess national competencies of the APRN core roles and at least one population focus area of practice for regulatory purposes. Once they pass the certification, they will be licensed as independent practitioners for practice at the level of one of 4 of the APRN roles with at least one of the 6 identified populations. They may specialize, but they cannot be licensed solely within that specialty area. If they do choose to specialize, the competency will be assessed and regulated by the professional organization that they're specializing in. Definition of APRN. They must have completed an accredited graduate level program in one of the 4 roles. They passed a national certification exam and continues to get recertified as required. Has advanced clinical knowledge and skills that prepare them to provide direct patient care. Practice builds on competencies of the registered nurse by demonstrating a greater depth and knowledge, increased complexity of skills and interventions, and greater role autonomy. They must be prepared to assume responsibility and accountability for health promotion and maintenance, as well as assessment, diagnosis, and management of patient problems, which includes the use of prescription, pharmacologic, and non-pharmacologic interventions, and has the clinical experience to reflect the license and who has obtained a license to practice in one of the 4 APRN roles. The CNP, or Certified Nurse Practitioner, provides direct primary care and acute care across settings. They practice autonomously across all areas. They diagnose and treat patients with undifferentiated diagnosis and symptoms, as well as those with established diagnoses. They also provide initial and ongoing and comprehensive care, including but not limited to prescribing medications, interpreting labs and imaging, prescribing durable medical equipment, and making referrals. The APRN title is a legally protected title, so not anybody can use it. You have to be licensed or certified. A little bit about the history of APRNs. Each state's Board of Nursing establishes statutory authority for licensure of RNs under the authority of the Nursing Practice Act. Any title, even those issued by national certification, only carries legal status if that title is recognized or authorized in statute or regulation. In 1995, boards of nursing directed the NCSBN to work together with nurse practitioner specialty certification organizations to produce legally defensible, psychometrically sound nurse practitioner exams that are sufficient for regulatory purposes after apprehensions about regulations were being brought up regarding that the exams were not constructed for entry-level use. During the 1995-1996 years, multiple certification groups met and worked on producing a mutually acceptable process and granting state authorization to nurse practitioners. Later, the groups met again and agreed to a third-body review process. In 1996, the American Nursing Credentialing Center, the ANCC, reported that regulations were being met by most criteria with a few minor recommendations for improvement that were addressed. There's 3 types of practice authority in the United States right now. There's the full practice authority, the reduced practice authority, and the restricted practice authority. The full practice authority states that state practice and licensure laws provides for all nurse practitioners to evaluate patients, diagnose, order, and interpret diagnostic tests, initiate and manage treatments, including prescribing medication and controlled substances, under the exclusive licensure authority of the State Board of Nursing. This is the model recommended by the National Academy of Medicine, formerly called the Institute of Medicine, and the National Council of State Boards of Nursing. There are currently 23 states that practice the full authority nursing. These states are Alaska, Arizona, Colorado, Connecticut, the District of Columbia, Hawaii, Idaho, Iowa, Maine, Maryland, Minnesota, Montana, Nebraska, Nevada, New Hampshire, New Mexico, North Dakota, Oregon, Rhode Island, South Dakota, Vermont, Washington, and Wyoming. The reduced practice states that state practice and licensure laws reduce the ability of nurse practitioners to engage in at least one element of nurse practitioner practice. State law requires a career-long regulated collaborative agreement with another health provider in order for the nurse practitioner to provide patient care, or limits the setting of one or more elements of the nurse practitioner practice. There are currently 16 states that fall into this category. And then the restricted practice authority states that state practice and licensure laws restricts the ability of nurse practitioners to engage in at least one element of nurse practitioner practice. State law requires career-long supervision, delegation, or team management by another health provider in order for the nurse practitioner to provide patient care. There are currently 12 states that fall into this category, including North Carolina. In 2016, the U.S. Department of Veteran Affairs gave advanced practice registered nurses access to practice in VA facilities without any restrictions. North Carolina is a restricted practice state and is regulated by the North Carolina Board of Nursing and the North Carolina Medical Board. North Carolina requires a certification for licensure. The Nursing Practice Act regulates the practice of nursing in North Carolina and guides the work of the Board of Nursing. The North Carolina Medical Board Nurse Practitioner Law states that any nurse approved to perform medical acts, tasks, or functions may use the title of nurse practitioner. It also states that a supervising physician must provide the nurse practitioner written instruction about indications and contraindications for prescribing drugs and a written policy for periodic review by the physician of the drugs prescribed. The North Carolina Board of Nursing scope of practice states for nurse practitioners that the following. A nurse practitioner shall be held accountable by both boards for the continuous and comprehensive management of a broad range of personal health services for which the nurse practitioner is educationally prepared and for which competency has been maintained, with physician supervision and collaboration as described. These services include, but are not restricted to, promotion and maintenance of health, prevention of illness and disability, diagnosing, treating, and managing acute and chronic illnesses, guidance and counseling for both individuals and families, prescribing, administering, and dispensing therapeutic measures, tests, procedures, and drugs, planning for situations beyond the nurse practitioner's expertise and consulting with and referring to other healthcare providers as appropriate, and evaluating health outcomes. Annual renewal and 50 contact hours of continuing education each year are required of APRNs. And the supervising, in North Carolina being one of the restricted states, the supervising physician shall be continuously available for consultation. North Carolina is working to become a full access state, full practice authority state. It's just taking time. Currently, we are fighting in Raleigh and in DC to make that happen for North Carolina. Thank you so much. Have a good day.